Good afternoon and welcome everyone to this patient-focused webinar. My name is Dave Burns from InsightTech, and I'm pleased to be a part of today's virtual educational event. If you would, please be patient for another minute or two as we allow everyone to get signed on, and then we will begin our presentation. Thank you. Very good. Looks like we have a good number of attendees signed on, so let's go ahead and begin. First and foremost, I just want to thank each and every one of you for your concession of time today. We are certainly appreciative and grateful for taking such opportunity to join us. The goal of today's presentation is for educational purposes. We are very fortunate to be hearing from Dr. Damiano Barone from Houston Methodist Medical Center Neurosurgery Department, as he will be discussing focused ultrasound as a treatment option for patients diagnosed with essential tremor or tremor-dominant Parkinson's disease. As questions arise during the presentation, and we encourage any and all, please utilize the question and answer button located on the bottom of your screen to author any such questions. We will have time after the presentation to answer the questions that are asked within the chat. So again, please take advantage. I want to begin by introducing you to today's presenter, Dr. Damiano Barone. He is board certified neurosurgeon who specializes in complex epilepsy, along with surgical treatment of patients with Parkinson's disease and essential tremor. He received his medical degree from the University of Federico in Naples, Italy, and residency inclusive of neurological surgery at University of Cambridge in Cambridge, England. Fellowships at Walton Center for Neurology and Neurosurgery in Liverpool, England, and the Mayo Clinic in Rochester, Minnesota. Welcome, Dr. Barone, and thank you as well for your time this afternoon. The floor is all yours.
Thank you very much, Dave. Thank you for inviting me to give this talk. I'm very passionate about these treatments because it really makes a difference in patients' life. So, thank you for introducing me. So, just a few more notes. I run the functional practice here, which is both clinical and academic, in parallel with my clinical work, focusing on patients with functional disorder, including essential tremor and Parkinson. Also run a large translational lab where we try to develop new technologies to help people that at the moment don't have available treatment to them. No, I don't have a significant disclosure for this talk. Today, we're going to talk about not just focus ultrasound. We're going to focus on essential tremor, which and what it is, how does it manifest and progress, and then talk about focus ultrasound. What is focus ultrasound? Who is eligible for these treatments? And what are the expected outcome? What's both in the short term, in the long term? Happens on the day of treatment, and some of the other details that patients always would like to know. Anything that we are missing, any question that you have, please feel free to ask at the end, as Dave said, and I will be happy to answer. So let's talk about essential tremor. Essential tremor is defined as familiar, idiopathic, benign tremor. It's a condition that is not linked to anything worrying in the brain. People sometimes get worried when they get symptoms. It's not linked to brain tumors or any more serious genetic disease, but nevertheless is disabling. And people with essential tremor, in particular when it progresses to more advanced stages, struggle with simple tasks of life, including drinking, eating, and other daily activities. There is no known cause for essential tremor. There is no test or scan that people can do to find out if why the essential tremor is, but we know how it manifests, we know how to diagnose it, and we know how it progresses. In many families, there is a strong family history. It's very common for someone with essential tremor coming through the clinic saying, oh yes, also my sister, my uncle, my grandfather was suffering for tremor. So up to 50% of cases have a genetic relationship. Is progressive. It starts with mild tremor, and in many situations, it does progress to a more disabling tremor over the course of life. It's over the years and decades. It's over 10 million people in the United States suffer from essential tremor, and there are treatments. There is pharmacological treatment, there are invasive treatment that we're going to discuss here, but an astonishing figure is that many people don't seek treatment, even if it's available for them. They're not aware that there are tablets that can be taken, and there are uh, and there are operations that can be done, which are quite low from a complication and side effect profile, but could be really impactful in the quality of life. So let's talk about the numbers. So essential tremor go around 7.4 million people. Of the 7.4 million, only 1.5 million actually received the actual diagnosis of essential tremor. Of these 1.5, nearly half have drug refractory. So they tried the medication, usually it's primidone or propanolol. These are the two medications of first line of choice. But despite this medication, the tremor continues, and around 75,000 of them are eligible for more advanced treatments. These advanced treatments tends to be 1,500 deep brain stimulators and 2,000 focus ultrasounds for the last numbers available. And from the Parkinson disease side, the numbers are similar. There are 1 million. The diagnosis tends to be done in more people, in the majority of them, and but only few go and have a procedure. What it means that there is an available treatment, but this treatment is not, just doesn't penetrate. And I think it's why webinar like this and information are important, because people just need to know what is available to them and then can make a choice if that is what help them. If there are always risks with any procedure, but if you don't know that the procedure is even available, you cannot make that decision. And then what happens is, as these figures show, almost 97% of people go untreated when they can actually have a life-altering procedure for them. So what is available at the moment? We talk about pharmacotherapy, with propanolol and primidone being the first lines. Every patient coming from the clinic, even if he's interested in having a more invasive operation, they will still be treating with a medication first. Because if a small dose of medication doesn't give any side effects and reduce the tremor to a level that a person can live a normal life, there is no reason to go to the next stage of the procedure. But as we see in many people, despite the medication, they either have side effects or they just doesn't control the tremor. Those patients should be assessed in an academic center, in a multidisciplinary team, which at least brings together the neurologist and the neurosurgeons to offer the more advanced operation. There are quite a few lists of operations that have been done over time. Focus ultrasound, which we'll be talking about, deep brain stimulation, and then more historically, there is radiofrequency ablation, stereotactic radiosurgery, and of course, there is toxin that can be injected in the muscle to try to kind of weaken the muscle so it shakes less. No ideal, but it's definitely an option. So let's talk about focus ultrasounds. First of all, what I want to say is that all the treatment, the invasive treatments, they all share a common mechanism. We know that by stopping a precise part of the brain, in whatever way we do that, that tends to reduce the tremor. This specific part of the brain is in the center, is part of a structure called the thalamus, and in particular, there is a substructure called the VIM. We know that when the VIM is lesioned, blocked, it stops the network and reduces tremor in patients with essential tremor. Now, you can do that in a variety of modes. You can do that with by inserting an electrode and stimulating with electricity, or inserting a wire, burning that part of the brain, or with focus ultrasound, where energy is delivered to that part of the brain to create that sort of lesion. Focus ultrasound is not a new treatment, although it's becoming more and more popular. There is quite a lot of science and research and trials that have gone into it. Here you can see the key milestones. Insightec is the main company providing focus ultrasound, which was founded in 1999. In 2005, there was the first treatment. 2016, there was the first FDA approval for one-sided treatment. And we will talk about one side and second side later on in this presentation. And then as developed for other application, and more recently we had long-term data. So it's a very established treatment, just newer than the other invasive procedure that we talked before, but nevertheless grounded in quite robust science. It's all based on delivering energy to a single point. So it works by using ultrasound waves. The machine is, as you can see over here, let me see actually, the machine is inserted in a normal MRI scan, and this machine is able to deliver ultrasound waves. The ultrasound waves come from around 1,000 elements, and every single element of this 1,000 don't do very much to the brain. But then when they meet to specific spots, they raise the temperature inside the brain, and they cause the lesion. And again, this is extremely precise because this is done inside the MRI. So live, we can see how the temperature is raising and exactly which part of the brain that is happening. And even more importantly, because it's an MRI, it doesn't use radiation. So it's not like gamma knife or X-rays. So it takes away all those risks of radiation, including risk of tumors. So the way that it works, and we're going to talk about actually what happens on the day, but when the patient lies down, is inserting that in that helmet, and sound waves do meet at that point. Now, that point will be the same point that would be hit with the DBS and with the radio frequency, with the gamma knife. It's not about doing something different in terms of targeting, but it's doing something different how to deliver the lesion. And here you can see that is before and after treatment. Patient is asked to draw a spiral, and that's with essential tremor, very difficult. And then soon after treatment, on the same day with the patient on the table, you can see the effect that focus ultrasound has. So who is suitable for treatment? Well, first of all, every patient needs to have a confirmed diagnosis of essential tremor or tremor-dominant Parkinson disease. So this is not a treatment that is just given by the the neurosurgeon. Every time I do this procedure, I will have a neurologist next to me, and you should demand to have a neurologist present for your treatment for safety. And the neurologist and the neurosurgeon will do this treatment, so the diagnosis will be confirmed and then treated and proven. Patient needs to be 22 years or older for essential tremor, 30 years older for Parkinson disease, needs to be able to tolerate the procedure in awake. This procedure is done completely awake. One is an MRI, although there is a short sedation to put the frame on, as we will see in the later slides. We want to be awake because we want to see the effects of the lesion, both in terms of reducing tremor and avoiding side effects. So there is quite a lot of communication between the treating team and the patient during the procedure. The main contraindication is MRI contraindication. So if someone cannot have an MRI, then unfortunately cannot have this procedure because it's carried out inside the MRI. And the second thing is the skull density ratio. That's an important point. Every time that someone comes to the clinic, the first thing he will have is a CT scan. Ultrasound waves only travels in media, which means cannot go through air. It can only go into water, body tissue, brain. So the ultrasound waves to come from the machine to that part of the brain has to travel that distance. And that distance outside the head is filled with water, so that is fine. And inside the brain is a water environment, that's fine too. The only part that is problematic is the skull in itself. The skull is actually not just a thick bone, it's bone with some locule of air inside. And what the skull density ratio means is the proportion between quantity of bone and quantity of air. So this is actually changed. The FDA has now proved it can be 0-30, which means 30% of the bone needs to be bone and 70% air. So if it's less than 30%, then the patient cannot have focus ultrasound. So I'm just going to show you a patient that underwent focus ultrasound, Mitchell. I think he really tells a nice story, and so I'll let him speak.
I've always had essential tremors since I was a child. In a work setting, I need to write, I need to be able to sign contracts, I check into hotels, and the shakes hurt. I mean, it makes it very difficult for me to get through those parts of life. I found on the internet the procedure involving the focused ultrasound, and it was really compelling. I don't have to have a traditional brain surgery. The first thing I'd like to do after the treatment is to sign my name. It sounds really simple, but it's a wonderful thing for an individual who's struggled to sign your name when you're trying to check into a hotel, rent a car, or do anything. So if I can sign my name without having my hand shake, that's going to be wonderful.
So far, there have been over 30,000 focus ultrasound performed worldwide, and it's going up and up every year in an exponential fashion. So it's a very effective procedure, and more people are aware of the procedure and talk to other people, and they just say, why didn't I have it before? The 5-year clinical studies are very encouraging. Show that people that had underwent focus ultrasound maintains the control of tremor over time. Now, in my personal experience, you have best tremor control soon after the procedure. There is slightly comeback of the tremor, but very little in around 6 months. And then after 6 months, whatever the control has been is what is left, what it will remain for the decade after. The actual numbers say that 73% of patients will have a tremor improvement at 5 years, which is quite a lot. And the number is much higher at definitely 6 months at year one. The most important here is the fact that there are no serious adverse events. So there are not complication that have disabled the patient. For the Fox ultrasound is pretty safe. There are something that happens, but usually it's temporary. It's in terms of imbalance, a gait problem, some numbness, and some headache. But the headache and the head pain is very much related to the day of surgery, because to do this procedure we have to use pins, and we will see that in a second. But overall, it's quite safe procedure. So what happens on the day of treatment? Let me show you here.
You will lay down on the treatment bed inside the MRI scanner. The medical team will be in the control room, and you will be conscious and able to communicate with them. Your head will be positioned in the focused ultrasound helmet, which is filled with water, and you will have a blanket to keep you warm. You will be given a stop sonication button if for any reason you want to stop the procedure. MR images are taken to plan the treatment. Your physician will first apply light doses of ultrasound energy to identify the right spot in your brain for treatment. Then, full intensity ultrasound energy will be applied. The treatment bed will move in and out of the MRI. After each application of ultrasound energy, you will be asked to do tasks such as drawing spirals. Just so the physician can evaluate the improvement of your tremor and any potential side effects.
So let's go a bit more in detail. So the treatment actually starts when in clinic. In clinic, the patient will undergo 2 scans, which is one the CT scan and one is the MRI. The CT scan is required to check if the patient is eligible for the treatment, to calculate the skull density ratio, and then there will be the MRI. With the MRI, the neurosurgeon, me, will spend hours planning the targets. The targets will be done on a specialized software where we reconstruct all the pathway inside the brain, called the system called tractography. So we will see exactly which part of the brain does different things. And the things that are important are the motion and the tremor and the sensation. The tremor is the part that we want to treat, where movement and sensation, so the ability to move the arm or the ability to feel, is the bits we want to avoid the side effects. The spot has to be extremely precise. The spot is planned on the MRI and then is transferred on the Fox ultrasound machine. That is done all before days before surgery. On the days of the treatment of the Fox ultrasound, and the patient comes, the patient is checked in. This is the part that people like less, but it requires a full head shave, and that is because we cannot leave any air in between. There needs to be a good fitting in the machine, and then there will be some more discuss with the anesthesiology team, and there will be a short sedation. The sedation is required because the patient has to be fitted with a frame, which is a helmet that is fit in the head of the patient, fixed with 4 pins, and could be slightly uncomfortable during the fitting. That's why we use sedation. But then after 5-10 minutes sedation, the patient is woken up and won't feel anything. Then it will be transferred from the area where we do the frame to the MRI scan. It will lie down, and then we will go, you heard the word sonication. Sonication is basically the delivery of the ultra waves into the brain. We do that in a sequential manner. We don't go straight to the highest temperature to make the lesion in the brain. We start with lower temperature because we want to first check a few things. Again, to go in be more details, some people like to know the really precise details. We do first 2 sonication that just raise the temperature of the brain to 42, to a temperature that basically we're able to see using the MRI. We use MRI thermography, which measure the temperature inside the brain, and then every time the sonication is done, we see exactly where the spot is. And then we're going to check that that spot is exactly the spot that I planned before. After these 2 sonication, there's a third sonication where the temperature goes a bit higher, where it does cause some cell dysfunction, but not lesion yet. It doesn't destroy that bit of the brain that we want to lesion. And that is just to see, do we have an effect on tremor? So we go back inside and we check with the neurologist if the tremor has reduced enough has reduced to a certain extent. It doesn't disappear at that point, it just reduces, but we know exactly we are on the right spot because the patient has had a good effect. But also we checked, has he had any side effects? Side effect in particular, we ask any pins and needles, any problem with in talking. When everything is, we are safe, we do that as many times as is required to make sure that we have a good effect and no side effect. Then we progress to the last sonication, where we raise the temperature to the level where we cause the lesion, and that the treatment is done. They all takes around 40-50 minutes, and with us coming in and out the room to do these checks. Every checks, we will do the spirals, we will do the signature, and we'll do the lines. When that all is done, the helmet is removed, and the patient just have one last MRI to check that the lesion is established in the place where we want to go. The benefits of having this compared to other treatments, the main other treatment being deep brain stimulation, is that it doesn't require me to cut the skin, make hole in the brain, and it doesn't, compared to the gamma knife, doesn't use radiation, so it's pretty safe, it's pretty immediate. The change is on the day. Once that last sonication goes, the tremor goes from being there to not being there, as you can see. This is same day, same treatments. This is before and after. On the left is just before the treatment. On the right is on literally 15 minutes, well, 15 minutes after the treatment, just because the patient had to come off the MRI and sit down, but it's instantaneous. In terms of insurance coverage, this treatment, as I say, is very established. Every state is covered in every state. Now, let's talk about second sight. There is a difference between DBS, and Fox ultrasound. Many of the side effects that we see in this type of treatment, the imbalance, some speech problem, usually happens when both sides are treated. In DBS, you can treat both sides at the same time because the DBS is a reversible treatment where you can switch on and off the machine, where in Fox ultrasound is an irreversible treatment where we create a lesion. However, even if there is a side effect on one side, usually it's temporary if there is no side effects also on the other side. And the best way to do is to stage the treatment. So if someone wants both hands treated, this is done by FDA rules 9 months apart. So one day for example, the right hand is treated, then 9 months after the left hand is treated. The treatment is, in terms of eligibility, is the same as for first sight. You just have to wait to 9 months before you can have it. And this is the trial results. There has been shown to be 80% improvement at the 6 month follow-up, both in the tremor and in the functional disability. And the side effects are very similar to before. And again, they tend to be transient. In particular, if there has been no side effects after the first procedure. Now, if there be some side effect after the first site, then we'll have a discussion if the second side is worth doing or not. And many patients are happy with one side because the disabling tremor most times affects the dominant hand, and patients that have the dominant hand treated, they can go ahead and do many of the things in life they want to do. So the second side is nice to have, but this is a quality of life operation, so it really should be done when it does affect the quality of life. And that's me.
Very good. Thank you, Dr. Baroni. Take a short break here for a second. I want to purposely keep this slide up for our audience. And please take note as far as the information conveyed here. Either jot it down if you could, and or take a shot with your phone. But this will take you directly to Dr. Barone. The other thing, and you touched on this, Dr. Barone, if you would just underscore once again a typical patient candidate's initial visit to the clinic and what the expectations would be.
So this is specific for Houston Methodist. We try to do an integrated care with the patient coming only one day. There are quite a few things that needs to happen before the patient, before the patient can undergo a Fox ultrasound in terms of scans, physician that need to be seen. So let's say that the patient has essential tremor, but this was just diagnosed by the PCP. The way that the patient will come to us, he will contact us in one of these numbers, and he say, "I have essential tremor. I'm interested in a treatment, Fox ultrasound or DBS." The patient will start coming in the morning and will have a CT scan and a neurology visit. The CT scan, as we said, is to see if they're eligible for Fox ultrasound, and the neurologist to make sure that all the conservative measures have been exhausted, that the medication have been tried, and there is nothing else that can be done before proceeding to a more invasive treatment. Then you will see me, and we will discuss the different options, Fox ultrasound, deep brain stimulation, and if after discussion is what the patient wants to do, at the end of the day, we'll have an MRI, and the MRI is needed for the planning of either procedure. So in one day, we'll have everything done that needs to be done for surgery. Then there will be a pre-op visit before the surgery itself, and then the next stage would be the day of surgery, of treatment, and which we talked about. And after that, I can also maybe touch on the follow-up. A standard patient had one side treated. I see them 2 weeks after, just to make sure that there is no acute problem. And then the follow-up is at 3 months, 6 months. At the 3 months is just we'll have the first MRI and the first check, make sure that the tremor is progressing well. And then at 6 months, there is the same MRI they had before the first treatment, and decision if the contralateral side needs to be treated. Now, if the patient wants the contralateral side treated, then in 9 months, we will proceed with the second side. If they don't want it treated, then I will see them at 12 months just to check the long-term outcome.
Very good. Thank you. That was a very thorough summary, which I know our audience certainly appreciated. And I think to kind of sum it up with the offering there at Methodist, it truly is a concierge service and visit. So thank you for going through that. We've got a number of questions. I want to continue to encourage our audience to bring those forward at the bottom of your screen at the Q&A. So here's number one to you, Dr. Barone. If you could simply touch upon the background you went through as far as training regarding focused ultrasound treatments to date, because I know with our centers across the country, we've got a variety of folks with different ages, et cetera. But if you would touch upon kind of what you bring to the table, that will probably best answer this first question.
Yeah, no, thank you for this question. I've been extremely lucky in my training. I managed to train in some of the top institutions in the world, but in particular in focused ultrasounds. During my first fellowship, I was in the National Center for Focused Ultrasound in United Kingdom. So every patient requiring focused ultrasound will be referred to this center, and we will do multiple focused ultrasound every week. And being a high volume center, there has been a lot of interest in research and in advanced treatments. Focused ultrasound is a way to deliver energy. The key behind is to make sure that the target is right. So everyone can push the button and deliver the treatments. Where the key expertise is in finding the sweet spot that that point in the brain that gives the best effect with the minimal side effects. And I had the chance to do that at high volume during my first fellowship, and then during my second fellowship, I had a chance to refine even further, being at the Mayo Clinic and doing more procedures there. And then here in Houston, even more lucky because when I joined, we established the program with the latest machine available called the Prime. So this is the newest. There are few in the countries, and allowed us really to push the boundaries of what is possible with Fox Ultrasound.
Very good. Thank you. And again, to the individual that inquired with that, hopefully that did answer your question. Number two, if you would, please explain the difference between deep brain stimulation and focused ultrasound and how you differentiate what is best for a patient candidate.
So they are both good treatments. So I said there were multiple treatments I discussed. I usually advise against radio frequency, and which is basically putting a wire to burn the brain, and the stereotactic radiosurgery. Those really are not on the table for me. I think the two main treatments remain Fox ultrasound and deep brain stimulation. They're both appropriate treatments. It's a discussion. I am not biased because I do both. I am happy to do both, and it's a really patient preference. There are advantages and disadvantages in both. As we discussed, the advantage in Fox ultrasound is that it's very minimally invasive. You don't have to have a skin incision or a wire pass through the brain. But at the same time, has disadvantages, which you still have to wait 9 months to get a second site treatment. Now, in the long scheme of things, it's not that much considering a lifetime. But some people don't want to wait those 9 months. So if people really don't want to wait 9 months, DBS can be done on both sides at the same time. The other difference is about reversible and irreversible. The Fox ultrasound, once a lesion is done, that it is a lesion. Where in the DBS, when you do a DBS, you can always take it back. It's reversible. You can switch off the machine, and you don't deliver electricity anymore. Now, in a very young patient at the moment, probably my tendency would be towards deep brain stimulation, but for someone more with a bit more age on them, Focus ultrasound would be my preference. And the fact that someone has focus ultrasound doesn't mean they cannot have deep brain stimulation, and vice versa. I've done both. I've done focus ultrasound in people that had deep brain stimulation, and deep brain stimulation in people that had focus ultrasound. If for some reason one of the others, it's not common, it's rare, but it happens.
Very good. Pardon me.
So these are the main difference between the two treatments. I would say most people nowadays with essential tremor tends to present a bit later in life, and particularly when it gets a bit more disabling, most people will start with the Fox ultrasound.
Very good. Thank you. Next question, very common that we often get is individuals talking about their medication and post-treatment, will my medication be eliminated because right now I feel terrible when I am on them?
It's a great question. And the medication are not risk-free. Medication have side effects. They really affect life. This is a great question because I get it all the time, and sometimes maybe I should spend even more time. By treating one at a time, the other hand will still keep shaking. So definitely after the side treatment, some medication need to stay to control the other arm. When both are controlled, most patients manage to get off medication, but sometimes you still need some medication, but you might need much less, enough that you have less side effects. I would say the majority of patients manage to get off medication though.
Very good. And again, I think you're correct. Oftentimes it's going to be a deferral back to the neurologist in that regard, but great summary. You kind of touched about the low end on the age qualification. We have an individual talking about the other end of the spectrum. Is there an age limit for you? I am a healthy 86-year-old.
Well, 86 is 86 young old. It's my oldest patient that I've treated was 92, and it's a nice story because basically one of the main things he wanted to do is to go back and play banjo. And after treatment, he was back there and playing banjo. He managed. No, there is no really upper limit. As far as someone can lie down and can cope with that 50 minutes treatment, the procedure can be done. It can be really life-changing.
Very good. Thank you. If you would, please touch upon implant compatibility. This individual in particular talks about what I think is a metal rod in one of his or her extremities, but if you could handle both of those, implant capability or compatibility, and then if somebody does come with some type of rod, would that exclude this individual from focused ultrasound?
No, it's an excellent question. So most in medical implant nowadays are MRI safe, MRI compatible. The rods used to fix fractures, they are MRI compatible. The pacemaker and spinal cord stimulator, even deep brain stimulator, they are all nowadays MRI compatible. What happens is when they come on the day of treatment, the MRI and physics team is a quite big team involved in that. So the MRI, the radiologist, and the physics team will go there and check the MRI safety. They will check if you have a device, for example, like a pacemaker or a spinal cord stimulator, the characteristics. They will contact the company and they will see if the MRI is possible. Now, if the MRI is possible, the treatment is possible. Here in particular, we are one of the first few in the country that have treated people with certain type of spinal cord stimulators. We are just in the process of publishing a paper reviewing all these cases. So we are quite adept. That's why a big medical center makes a difference in doing this procedure compared to smaller center, because we've got also this extra expertise, including medical physics, to make sure that we can push the boundaries, that no one that can have this treatment will be excluded. It might take a bit more work because we have to do the research and make sure that that particular implant is compatible. But if it is possible, we will do it.
Very good. Thank you. Again, a very routine question, very common question, talking about additional tremors outside of essential tremor, i.e. individuals that may present to you with head tremor, voice tremor, leg tremor. Will focused ultrasound help resolve those conditions as well?
This is a more difficult question. This will require definitely a big interaction with the neurologist. In broad lines, I would say if the tremor is quite complex and involves more than just the hands, so it starts involving the core, the voice, all the parts of the body, probably DBS might be a better option. However, I've seen patients that say, you know what, the right hand is the thing that is disabling me the most. Can I have focused ultrasound anyway? I don't care if the rest is still shaking. It's the hand that is disabling me. And in those patients, I've seen some improvement of the rest, but to be on label, this is done for hand tremor. So the focused ultrasound is for hand tremor, where the DBS can address the other ones. So it's a bit more complex. There is not a blanket answer to this. It would really depend on the type of tremor, on the discussion with the neurologist, but there is a treatment available anyway.
Very good. Thank you. And I'm going to compliment that along those same lines. When an individual presents to you with gait, how would you handle that discussion as far as focused ultrasound versus other modalities?
Yeah, gait is slightly an issue because focused ultrasound, one of the very few adverse event and side effects could be gait problem. It's again on an individual basis. We have to see what the gaits, if there is a pre-existing gait issue, and if the gait is so if there is no pre-existing gait issue, the issue are the same. Usually after one site treatment of Fox ultrasound, even if there is a slight gait issue, as I said, is temporary. If it's not temporary and is still present over time, is when we have that discussion in maybe the second side will not be a good idea because it might worsen that gait difficulty. On the DBS front, we can control better because we can direct if we know that there is a side effect that involve gait, we might stop that electrode from working or revise the electrodes. It's both treatment have different way to cope with it, and again, it depends on when it happens and if there is a pre-existing history of gait impairments.
Very good. Next question. Talking about recurrence, if it does rear itself, provide your experience in this regard. You know, when is it that you would retreat a patient that maybe their response didn't last as long as anticipated?
It can be done again. There is all the different variation is some people that had Fox ultrasound can go and have another Fox ultrasound, or Fox ultrasound and go have DBS, or a DBS and go have Fox ultrasound. So retreatment, it's done, has been done. We do. Is it for the minority of patients that don't respond to treatment, so want to try something else? For example, I had a patient where one side worked well, the other side didn't work that well. So we know that this treatment does work to them. So repeating makes sense to achieve the same control that we achieve on the other side. So that's, yes, it can be repeated.
Very good. And I think, again, one of the forthcoming questions just talks about extended period of time. And I know you alluded to the 5-year data talking about tremor relief at 74 odd percent reduction. But again, just answering what you did about recurrence, it could be treated without a problem. Again, I'm going back to a question talking about Parkinson's and some of the treatments there and the medications there. That's going to be more of a DBS type question. Is a patient going to see a reduction in their Parkinson's medications?
So it depends. So for Fox ultrasound is done mostly for the tremor when it's tremor dominant Parkinson. So the medication for tremor will see a reduction, but the other medication for Parkinson tends to be the same. In DBS, yes, there is the idea is that you have a reduction in medication because the DBS covers also other aspects of Parkinson that is not just tremor, in particular the rigidity aspects, and the on and off effect. So yes, the drugs usually are lowered and rationalized in the DBS. I repeat, for the Fox ultrasound, treatment is more for the tremor dominant, and then for the tremor related medication, those can be for the essential tremor, the hope is to reduce them if possible.
Very good. Again, out to our audience, we're winding down a bit. We still have a couple more questions. So again, please take the time to pose at the bottom of your screen. What do you suggest? And this is a good one, good question. As far as your patients that ask about continuing education, what do you offer up to them? What do you suggest to them?
So, I mean, we provide quite a lot of information and a package when they attend us. We spend time discussing about the procedure. This webinar is another way to get more information. The Focus Ultrasound Foundation has a lot of materials that is available to the patient on the website, and nowadays people use Google and ChatGPT to ask questions, and I encourage my patient to do it, but then to discuss what they found with me, and so we kind of debunk false myths or verify some truths. So there is quite a lot of material there, but the main official material I would say is the one that you get from the office and probably the Fox Ultrasound Foundation.
Very good. And lastly, and again, a very good question. What do you suggest to your patients Post-treatment, they often ask, when can I go back to normal in daily activities? What are the precautions that you present to those individuals?
So after focus ultrasounds, there is that 1 week or two where there might be those temporary problem. We tend to give just to be careful, in particular if they feel a bit slightly unstable on their feet, just to be wary. But the reality is they can come back in their normal activity the day after. In particular, if the normal activity is more sitting and desk work, so they could also go back to work. But I will leave it probably 2 weeks for more physical activities. For DBS, it's similar, might take slightly longer. Return to work in DBS is 1 day night stay and looking after the wounds for 2 weeks. The return to work is very similar.
Very good. And then finally, will you explain again with focused ultrasound on the brain, are you looking for some kind of blockage in the brain? What is the sound treatment itself doing?
No, it's not blockage. The idea is that you raise the temperature. We know that when you heat something, you can damage it. So forgive me, I'm gonna, and maybe Dave can translate in Fahrenheit, but the international and I was trying to say during the presentation, then I stopped myself. But it's about temperature. So if we know that our body is at 37 degrees Celsius. They maybe can help me in do the translation in Fahrenheit meantime. But so our temperature is 37 degrees. That's what is the temperature in the brain. So the first sonication allow us to raise that temperature to 42, 43 degrees. That will allow us to see the difference. This is a temperature which is higher than the rest of the brain. So we see exactly where that is being raised. Then we know that above 48, 50 degrees Celsius, you start having the cells not to work properly. They are stunned. So that kind of cause that dysfunction, that only lasts minutes, and that is where we test the patient to make sure that the tremor does reduce. The body and the cells in the body, when you start reaching 55 to 60, is when the cells die. The cells don't work anymore. So what we want to do is not a blockage like a vessel. Some people that have a stroke and have a thrombus, that we want to clear that vessel. Here's the opposite. Here there are some pathways. So there are cells talking to cells, neurons talking to neurons, and the tremor has upset that pathway. And we know that and so there is a pathway that is acting a bit more. We know that by stopping that extra pathway that is acting a bit more, we stop the hand from shaking. We stop the tremor. So the idea is stopping that pathway by hitting that precise spot in the brain, by raising the temperature and killing those cells.
Very good. Thank you. Very thorough. Well, folks, that brings us to the conclusion. I just want to thank you again to our participants for your time and efforts tonight. You presented and posed some wonderful questions. Dr. Barone, back to you as well. Fine job. Folks, please take note once again of what we've got queued up here on the slide. And for additional information, please contact the office. I want to go back to one additional individual who inquired about slide deck availability. And if they can do so through your office, Dr. Barone, is that appropriate to direct them that way?
I think soon I will. This presentation was recorded, and I will try to upload it online.
Very good. Okay. With that said, I want to bid everybody a wonderful evening, and thank you again.
Thank you very much, Dave. Thank you, everyone.
Thank you, sir.